Welcome, everybody, to Rush University Medical Center Division of Nephrology Rush Renal Biopsy Conference for March 11, 2021. Today is World Kidney Day, an exciting day for all of us. We have a special guest, Dr. Kanar Javeri, who's professor of medicine at Hofstra Northwell in Long Island. He is also the editor-in-chief of Kidney News and an all-over good guy, and we're glad to have him join the faculty today. We have a good case it's Dr. Whittier's. Will be presented by Dr. Blank, one of our fellows. The activity code today is 481829. We are recording this. It will be available on YouTube in about a week. So please subscribe to our channel. You are muted if you're not faculty, so put all your questions in the chat room and we will try to address them on the chat board. The patient has been de-identified and we, as usual, have nothing to disclose. So let's get started with the case. I think, Sam, you're going to read it for us?
Yes. Okay. So the patient is a 25-year-old Black man with metastatic alveolar soft part sarcoma and seizure disorder who presented to RUMC with pain over his port site and was found to have an MSSA bacteremia. So he had a port placed 3 months ago for nivolumab infusions, which he was receiving for his metastatic sarcoma. On admission, his creatinine was around 1. His baseline was 0.5 to 0.7, according to our records. And during his admission, his creatinine continued to increase. And we have a little graph here. I don't know if Dr. Baxi, if you wouldn't mind pulling up our graph of his creatinine trend. There we go. So day one, obviously, when he came in around 1, and then as you can see over the next 5 or 6 days during his admission, he got up to the 3s. Back to the protocol. So throughout the time, he remained non-oliguric and never had hypotension or shock. His initial UA had a spec grav of 1.010, pH of 5.5, trace protein, trace blood, 10 white cells, 3 RBCs, and 3 granular casts. A renal ultrasound demonstrated echogenic kidneys with no hydronephrosis. His bacteremia improved with antibiotics. However, as we saw in the graph, his creatinine continued to rise, reaching a peak of 3.2 with a BUN of 46 on the day of biopsy. A little bit before his biopsy, we repeated his UA, and again, his pH was 5.5, spec grav 1.013. He had trace protein, 20 white blood cells, 1 RBC. His port remained in place with plans for removal. In terms of his past medical history, he had metastatic alveolar soft part sarcoma, as I mentioned, diagnosed at age 20. We don't have great records of his care before he came to Rush. It sounds like he was at another institution in Chicago, and then he had moved to Texas at some point. But from what we can tell, his malignancy was resistant to several chemotherapies, unfortunately for him. So he came to Rush, and then at that point started nivolumab and cabozantinib, a little bit of mouthful there, 3 months prior with some initial response, at least when he was admitted at Rush. He also has a history of seizure disorder as well as heart failure with reduced EF. Past surgical history, significant for port placement, craniotomy, a tonsillectomy. Social history, he was a non-smoker, no alcohol use, no drug use, and lives at home with his partner. No family history of kidney or autoimmune disease. A review of systems when we saw him was positive for pain around his port and a mild headache. Allergies, notable for shellfish. And medications prior to admission, he was on gabapentin, cabozantinib, as I mentioned, which is an oral tyrosine kinase inhibitor, nivolumab infusion, which is a checkpoint inhibitor, Synthroid, Keppra, omeprazole, Androgel topical, ibuprofen, and Lasix as needed. His exam, temperature, he was afebrile, 97.9, blood pressure 127/82, heart rate 82, respiratory rate 17. He was about 5'8", 131 pounds, or a little less than 60 kilos. In terms of his physical exam, Otherwise, he was a thin male. He appeared younger than his stated age, resting in bed at no apparent distress the time that we first evaluated him. Moist mucous membranes, no lymphadenopathy. His lungs were clear to auscultation bilaterally. CV exam was regular rate and rhythm. He had normal S1 and S2, no murmurs, rubs, gallops, no edema at that time. Abdominal exam was benign, no joint swelling or erythema. His neuro exam, he was ANO ×3, and then he had some mild erythema around his right chest port and was mildly tender to palpation around his port as well. So labs, sodium 139, potassium 3.7, chloride 111, bicarb 21. BUN initially was 12 and rose to 46 at the time of biopsy. Creatinine was initially 1.06 and then rose to 3.2. Glucose was 97, total protein 4.8, albumin 2.4. Calcium was 8.2 with an ionized calcium of 1.1. T-belly 0.6, ALK phos 51, AST 29, ALT 17. CBC was notable for white count of 7 with 97.5% neutrophils, 0.8% lymphocytes, and 0.2% EOs. Hemoglobin was 10.7 with hematocrit 30.7, MCV 91, and platelets of 138. As you can see, his CRP was pretty high, 195. We had a Vanc level on him of 23. As we mentioned, his UA had a spec RAB of 1.01, pH 5.5, trace protein, trace blood, negative nitrates, and leukoesterase, 10 WBCs, 3 RBCs, and 3 granular CAS. Urine albumin to creatinine ratio was 32 milligrams per gram, and his UPC was 247 milligrams per gram, and his fractional excretion of sodium was 3.7%. Renal ultrasound, increased echogenicity bilaterally. Right kidney was 9.8, left kidney 11, and no hydronephrosis. And then he underwent a percutaneous renal biopsy.
Great. Any questions for Dr. Blank?
Sam, what is his baseline platelet count? Is 138 where he usually runs, or has that been going down?
I'm not sure. It's my case, but I can look that up for you while we entertain other questions.
Any complement levels?
No, sorry, I realized I answered your question, but I was muted. I think that the platelets, he was kind of bopping around, like he dipped down to 100, then he'd come back up to the, mid 100s, and he was kind of up and down a little bit, but that generally seemed like that's where his platelets were. So he's a mildly thrombocytopenic, but that seemed pretty much unchanged for him. And then no, we do not have complements.
Hey Samantha, it's Kenar. Nice presentation. What antibiotics did he get? I assume vancomycin was one of them, but I didn't see any list of the antibiotics.
Yeah, he was on vancomycin initially until the cultures came back, and then he switched over to cefazolin when it was sensitive, and that was about on hospital day 3 or possibly 4 when his creatinine was around 2.
Great. Dr. Gash, do you want to start us off here with a differential diagnosis?
Yeah, so we have a young gentleman with history of metastatic sarcoma on a checkpoint inhibitor and a TKI who comes in with AKI, and at the same time he's got an infected port and MSSA bacteremia. So a couple of ways of approaching this AKI. His urinalysis is helpful in the sense that there are some granular casts in there, so there's going to be some ATN. If that's clinically relevant or not is to be seen, but ATN, we should be able to see some ATN on the biopsy. Whether the ATN is from his infection and potentially their normotensive or a hypotensive ATN in the setting of infection, or from, let's say, his TKI, that's kind of to be discussed. So that's one thing. You got vancomycin, which is nephrotoxic, can also give you that picture. An infection-related glomerulonephritis with, we don't have complements, but some of these the non-post strep ones, like the staph-related ones with IgA mesangial deposits, can sometimes be normal complementemic. So there is a possibility he would have immune complex, sort of like an infection-related GN as a result of his infection. Interstitial nephritis from checkpoint inhibitors is definitely on the list and high on the list. He came in already, his creatinine was up from 0.6 up to 1. So the vancomycin, as much as I want to blame that, I feel like that probably got, started after his AKI had already taken off. So that's, probably less likely. The interstitial nephritis, I'm going to put that pretty high up. The reason being that he came in with AKI, he's on, he was taking some NSAIDs, and also he's on a PPI, that it seems like being on a PPI and a checkpoint inhibitor increases your risk of developing interstitial nephritis. Other things you can get with checkpoint inhibitors besides interstitial nephritis could also be immune complex mediated GN. Those are more rare. Most of them get interstitial nephritis. You could also get podocytopathy type minimal change disease and things like that. He does not appear to be presenting that way. So of all the things that we've mentioned, I feel like interstitial nephritis is probably high on the list. It's really important to biopsy these patients because that's not the only thing they can get, and it's important to know what they have so you can treat properly. So interstitial nephritis with some pyuria in the urine is definitely up there. ATN, and then some kind of a glomerulonephritis, whether it's related to his chemo or related to his infection, to be seen. But I'm going to say 1, interstitial nephritis plus ATN, 2, just ATN without interstitial nephritis, and C would be some kind of a GN. Although it doesn't have a lot of blood, mostly pyuria, so I think interstitial nephritis is really kind of win here.
So Casey, I'm going to ask you several questions, then I'm going to pose the same questions to Kanar. This AIN from a checkpoint inhibitor clearly has a strong association with, PPI, which he's on. And I know the PPIs often have interstitial nephritis without, other signs or symptoms of an allergic reaction, for instance, eosinophilia, rash, etc. The AIN of PPI, if you will, whether there's the AIN of checkpoint inhibitors, whether there's PPI involved or not, how do you feel about it being this silent without having anything else systemically?
Yeah, you don't actually have to. I mean, the typical, rash, eosinophilia does not really necessarily have to be present. I feel like some of the cases that were reported, I mean, Cortazar had the largest series of them, 13 or so patients that he reported. Some of them did have it, but most of them, didn't really have any extra renal manifestations of interstitial nephritis, like we usually see a mild fever, some rash or something else. So the lack of those, I feel, do not rule out AIN. That's kind of basically what I'm going to say.
Kanar, what's your experience with this?
So based on my experience and also like larger series that have come out in the last 1 year, there are certain risk factors that play a role. So definitely PPIs now in 2 studies has been a major risk factor for AIN from checkpoint inhibitor. The other is the low GFR, hypertension, and what you mentioned, Roger, maybe another adverse immune event. So it's good to ask those questions. Does the patient have recent dermatitis, colitis, pneumonitis, some other itis from the checkpoint inhibitor? That's actually the biggest risk factor, and probably the best clue we might have, this might be an itis in the kidney from the same drug. So that's the more of the things we want to look at. In terms of urinalysis, it's completely useless in my opinion with checkpoint inhibitor AIN. I've been fooled many times, and I think there are studies showing that people can be fooled. So I would not go by that. And even looking at the urine sample, finding granular casts or WBC casts are not very helpful because checkpoint inhibitors can also cause ATN. Like pembrolizumab can cause ATN. So that's also been seen. The other question that's going on in the chat is the eosinophilia and eosinophils in the urine. both don't seem to be useful in general AIN or in checkpoint inhibitor AIN. I haven't used that since I graduated fellowship after that C. Jason paper from Mayo Clinic. I haven't used it at all.
What about the
Yeah,
time, Kanar, with the interstitial nephritis of protonics use versus the CPI?
What was the first part of the question?
The timing.
So the timing is challenging. In some cases, we have seen as early as like the first few weeks of therapy versus even as late as 3 to 4 months. The CTLA-4 seem to happen a little bit sooner. The PD-1 inhibitors much later, and PD-L1 inhibitors rarely we see AIN. So, and how long you be on the checkpoint PPI? I mean, that's a general AIN thing. It could be days versus years.
it's interesting to me because it seems like PPI is the new, sulfa or penicillin for AIN these days. And it seems like, you just want to be allergic to it, but you really don't need to be allergic to it. And then you take, you give the checkpoint inhibitor, and it just seems to bring it all out. And Kanar, do you know off the top of your head what % of cases of at least been reported, realizing there's reporting bias, do have a checkpoint inhibitor on board? I mean, a PPI on board?
Not offhand. That's a good question. I'm sure it's a good amount. I think a lot of it's not reported because the patient doesn't tell the oncologist. It's the nephrologist that asks about the PPI a lot of times. And it's possible just stopping the PPI might be good enough, but we don't know that also.
Yeah, PPI use is pretty ubiquitous. They're over the counter now. And so,
Yeah.
it's, kind of unusual that people don't take them. Casey, this cabozantinib is a VEGF inhibitor. Is that right? I believe it is.
Yeah,
So,
I think so.
yeah, I believe it is. So, what fits what, that we certainly see a lot of renal side effects from these now. What fits or doesn't fit that?
I mean, the ATN part does fit. The traditional VEGF inhibitors we think of, like with proteinuria, like a kind of a proteinuria, hypertension, like Avastin. I feel like these TKIs are more consistent with ATN. I mean, the low platelets, I suppose we don't have any hemolytic labs. I don't know if that's really associated. I have not, I mean, Kanar can correct me, but I don't know if this particular TKI, even though it's a VEGF inhibitor, has been associated with TMA per se, but the low platelets can go along with that. The AKI, obviously, that's why we biopsy these patients, because we really don't know. It could be anything.
And that's why you asked about the platelet count if it was dropping.
Yeah, that's kind of where I was going.
Yeah, so I'm a lumper, especially when you get all these new drugs that I don't know anything about. I just put them all in one category. And to me, that I see this and it says VEGF inhibitor, and I think of a TMA, but it's hard to believe that it would be that silent. Kanar, what do you think about that?
So it's not the most common of the TKIs. Every time I see one of these, it's a new one that pops up. But there's like maybe 1 or 2 case reports of this one specifically. I think I posted one of them in the chat. The biggest clue in most of these is hypertension, actually. So that's the first sign in most of the TMAs with these drug-induced. Weeks before, months before the creatinine starts rising, platelets start dropping. So, there was no hypertension that was worsening in the last few months. It's less likely this is TMA. But, we've been fooled with that. Yeah.
Maybe this is hypertension for him because he's actually septic.
Yeah.
Who knows?
It's possible. Yeah.
So the TMAs that Kanar, the TMAs we see with these, with these VEGF inhibitors, how often do you see peripheral evidence of that, or is it often just limited to the kidney? I mean, as far as full-blown TMA, what I mean is like schistocytes and dropping platelets and hemolysis. Is that the exception?
Yes. So systemic TMA is much rare with these drug-induced. I think most of them are more silent and more renal limited, unfortunately, and it's missed most of the time. That's why.
Yeah. So I mean, I guess it's still on the table, though the urine is pretty benign for something like that. I think that's I think that's kind of the message I'm getting. Casey, you kind of, I don't know, you kind of glossed over staff-related IgA. You wanna talk me out of it some more?
No, I don't want to talk you out of it. I want to keep that on the list. Like I said, he's got AKI and he's got a staph infection, so that has to stay on there. We don't have complements, nor does that really help in half the cases. So I mean, the pyuria here is, there is pyuria, so that could still be interstitial nephritis. There is AKI. The lack of hematuria probably makes me think maybe less so. But again, I think AKI with staph, that has to be on the differential until proven otherwise.
Great. Anybody else have any other comments before we spin the wheel?
Just on the vasculitis part, I think you had mentioned GNs with the checkpoint inhibitors. Actually, ANCA vasculitis is the most common GN, not as much as podocytopathy, so the immune complex. So it's actually ANCA negative post-immune vasculitis. Actually, it's the most common.
Yeah, I had a case last year that on a checkpoint inhibitor that really blew up on it and had what looked like a post-infectious, but probably I think it was a C3 GN that was really brought out by it. And the patient unfortunately didn't do very well in the long term, which a lot of people don't. If you're having a checkpoint inhibitor, you've got a pretty bad disease. But I think we're seeing more and more reports of stuff either de novo or being brought out by it. Maybe the second hit is you're brewing along with a complement pathway deficiency in this, and then you as the title of this the email says, you take the brake off and suddenly it takes off. Let's see who's going to read the book.
I like how the wheel it was speaking to us. It sounded a lot like Dr. Rodby, but it was coming straight out of the wheel. It was very strange.
The wheel has powers that are not understood.
We've learned to not question the wheel.
Dr. Baxi.
All right.
There's no excuse for messing up the mouse today then.
Yeah, exactly. I can only blame myself. All right. So we have a low power trichome stain. And at this view, we're looking really for fibrosis. And you're not seeing, there is some, we'll see with the different stains, but there's seems to be some of these don't seem to be completely back to back. So there may be some fibrosis, or maybe it doesn't look like interstitial edema, but at this view, it's hard to comment more than that. There's definitely areas here that seem to be either fibrosis. It seems a little cellular too, but we'll see in the other stains. This looks a little more like medulla. I don't see any glomeruli there. The glomeruli on this view, it's hard to see them really. We'll see them at higher power, but there seems to be some, maybe, I don't know, David, if you call it like 25% fibrosis.
Yeah. Why don't you go to the this thing
one
was a little deceiving. So,
yeah, that's why it seems like there's some back. Oh, well,
the tubules aren't small and atrophic. Yeah,
there we go. Well, it's low power H&E.
Yeah.
You can definitely see here a lot of that interstitial. You can see it's very hypercellular. And we'll see at a higher power what these cells are, but you can see that kind of just stands out. It's completely hypercellular here. The glomeruli at this view, hard to comment on, but the predominant feature here is interstitial hypercellularity. And we'll see kind of what the cells are, which goes along with the concern for interstitial nephritis, which was number one. Anything else on this one, David?
No, yeah, you could see it's diffuse.
Yeah.
And dense. And the glomeruli look to be uninvolved.
Yeah, they don't look as cellular here, but we'll see at the higher power.
David, those tubules look pretty separated.
Yeah, that's the thing.
Right?
Yeah.
Even here.
Is that edema or is that fibrosis?
At this point, I think it's edema. The most helpful stain actually is the PAS, because if they have Rinkin shriveled basement membranes, that they're scarring down, they're atrophic. But sometimes, yeah, it's just a cellular infiltrating edema separating them.
Okay. Yeah, because I mean, they seem quite separated. So we have a high power H&E. You have 2 glomeruli in the screen here. We'll start with this glomerulus. The glomerulus looks pretty, well preserved. I don't see, on a differential, we had IgA or SAF related GN. There's no crescents here. Maybe you see some areas of hypercellularity, but overall, at this view, it looks pretty pretty normal.
Yeah, it may be a little ischemic as there's some space between the tuft and Bowman's capsule. Yeah.
The loops look pretty open. And yeah, don't see anything. This one looks, even here, a little bit more, but overall, here's a little area of hypercellularity. Looks like this is the hilum right here.
Yeah.
So yeah, some areas I would say, it's not global segmental areas of hypercellularity, but otherwise, I don't see any crescents, any segmental necrotizing lesions within this glomerulus here. But the interstitium is really what stands out. I mean, you have dense hypercellularity, and at this power, they look primarily. I don't see any eosinophils. They look like lymphocytes, but we'll see it at other angles. But you can see it's kind of all over. And looking at the tubules, I guess we'll see at different views too. But it's kind of what you're seeing, just dense hypercellularity.
Yep. Yeah, I agree.
And interstitial nephritis again, which was on the differential for us, number 1. High power H&E, again, 1 glomerulus on the screen here. Yeah, there is some space between the tuft and the Bowman's capsule. Sorry, the Bowman's Bowman's space is increased here. So, but I don't see any other kind of active lesions here. I mean, again, not even any hypercellularity, but you're seeing this dense interstitial hypercellularity. Again, looks like a neutrophil right there, actually. Hypersegmented, multinucleated cell, but otherwise it looks like mainly lymphocytes.
Yeah, so I can make out an occasional plasma cell. If you go straight over to the left, just go straight west, up 3 cells. Yeah, right there.
Yep.
So you see that's the nucleus, and then off to the bottom is the kind of purplish cytoplasm abundant. Yeah, so that's a plasma
Maybe that one
cell.
too. Yeah, and that looks like a neutrophil right there.
Yeah, then there's rare scattered neutrophils, but predominantly, as you said, lymphocytic, some scattered plasma cells, and
it's quite dominant though.
And no EOs are granulomas.
Okay, good. PAS stain, 1 glomerulus here, high power. Doesn't seem to be. This one actually looks a little better, not as ischemic looking as that one, and in terms of really, it looks normal. I don't see any expansion of basal membranes, no hypercellularity, and then you're just seeing this dense, infiltrate in the interstitium. Now look at the tubules. The brush borders actually seem intact on these. Maybe even here. I don't know if that's.
Yeah. So then, do you see any active tubulitis?
Yeah. Here you see some.
Yeah.
This one right here. That's kind of, you see.
Right. So those smaller nuclei are lymphocytes. Yeah, right there. The other cells are tubular nuclei. And then as you go look at the tubules at the bottom of the screen, you could see.
Here's one. You have some.
Yeah, there's
here.
one there. To the right, there's a
here.
poly. Yeah.
Yeah, poly there.
Active,
Here, so there's some tubulitis too from this interstitial.
Yeah.
From this, we're assuming we'll see what the ultimate thing was, but we're definitely seeing tubular interstitial berry disease is what's predominant here. It's quite severe.
Yeah, I don't see adhesion there.
Right here.
Yeah, that's just a little soft tubular epithelium there. Yeah, I don't see a segmental scar. That's the hilum at 6 o'clock. Okay.
Yeah, so just really, and then no EOs, again, primarily. Here you're seeing a lot of, that looks like is that a plasma cell right there? Maybe.
Where's the pointer? It's kind of
bouncing
around.
No. Maybe that one. We'll see them scattered, but primarily just
the H&E is the best stain for that.
Jones stain, silver stain. You have 1 glomerulus here. Nothing breaks, no breaks, looks preserved. No hot spikes or holes. Pretty normal.
Yep.
And at least so far, no evidence of TMA.
No evidence of TMA, yeah. So this is, let's see, just highlighting the interstitial. This is just H&E. And I guess you can see the different interstitial cells much better here. And you're seeing predominantly, again, lymphocytes with scattered, you've seen some scattered plasma cells, but I don't see any EOs.
Right. There's a cluster of like 3 plasma cells just above the middle of the screen, where yeah, down a little bit. Yeah, right there.
Yep.
That to the right of it, up to the left. Yeah, those are 3. Those are plasma cells with the eccentric nucleus and the purplish cytoplasm.
Predominantly lymphocytes.
But yeah, I agree. Predominantly lymphocytes.
And tubulitis again here. This is kind of invading. So really severe interstitial disease here.
Yep.
So a PAS stain, again, of the interstitium. What you're showing here, now this, I don't even see a really great brush for here. Is this like it looks like almost a cast.
Well, there's a very active tubulitis with
Tubulitis?
all the lymphocytes there crossing the basement membrane, attacking this tubule. You know, if this were a transplant, we would say it's a cellular rejection.
And that's why you're seeing all this. Otherwise, I mean, this is just bad. I mean, it's hard to even tell. These tubular invaded with all these cells. I mean, it's really active tubulitis here.
Yeah, and you could see the basement membrane here. It's not an atrophic tubule, right?
It's unhealthy a little.
It's been shrunken yet, and there's the space between the tubules is what we saw in the trichrome. So it's kind of a mixture of cellular infiltrate and edema, but over time this will scar over. So that's the reason to turn this mechanism off.
Hey, David, there's 2 tubules there, though. The one in the top left.
Yeah.
Is that a distal tubule with all those nuclei, or is that a proximal tubule with bad tubulitis?
Yeah, it's the latter. Yeah, I think that's a proximal tubule. I see some brush border over on the right a little bit. Yeah, there. And then the darker nuclei are lymphocytes.
Same here. Okay. So I'm immunofluorescence IgG negative. And so I'm assuming everything here was negative as well.
Yep.
IgA.
Yep, everything negative.
So EM, you have your blood space and urinary space here. You're not expecting any type of deposits based on our immunofluorescence. So kind of going around, I don't see any clear deposits here. Looking at the podocytes, look pretty healthy here. I mean, very few areas of any effacement. We'll see, you'll measure it out, but it looks more or less in the normal range. But we'll wait for the measurement, but pretty good looking EM.
Yep.
Another EM blood space, and then your urinary space out here. Podocytes look pretty healthy. There's some area of effacement here, so maybe focal. No deposits that I can see. Yeah, really otherwise normal. And we'll see the measurement here. So that's within normal limits. Again, same thing, urinary space, blood space, urinary space, no deposits. Podocytes look very preserved, very little effacement, if any.
Yep.
So the final diagnosis here would be, I would say, acute interstitial, it was primary acute interstitial nephritis with pretty severe tubulitis and seemed predominantly lymphocytic.
I'm used to asking for what's the C4D stain at this point.
Yeah, exactly. What's the C4D and where's the transplant hiding?
Yep, good.
That's great. So we have acute interstitial nephritis with a lot of tubular damage, a lot of very strong tubular invasion with this inflammation. Casey, is there anything that would tell you that this is a checkpoint versus, I mean, obviously that's the likely thing, but is there Is there any way, or is this going to be a diagnosis of likelihood?
No, I don't think histologically you can tell him it's interstitial nephritis. So it's, I think the fact that he's on a checkpoint inhibitor and on a PPI with this biopsy, I mean, that's, you have to believe that's what it is.
A little surprised we didn't see EOs. I know we often see a lot of EOs in PPI-induced AIN, but I don't think that changes anything here.
Hey, Roger.
Yeah.
So actually this just, I think, fresh off the press a few weeks ago, a paper from Mayo Clinic from Sandra Herman's group looked at CRP and urine retinal binding protein to creatinine ratio. And patients who had checkpoint induced AIN had a much higher level of CRP and this elevated urine retinal binding protein to creatinine ratio. I've never checked retinal binding protein to creatinine ratio. I've been checking that in the last few months because of that paper. And actually, to me, it's not very specific. I found it elevated randomly in other things too. CRP is interesting because, again, it's an itis and very high CRPs. I'm seeing like 300, 400, 200, super high levels that we saw even in COVID. So that could be a clue, but again, it's non-specific.
Is that the level of CRP, was that compared to non-checkpoint inhibitor induced AIN?
I believe so. I can find the paper and put it in the chat.
Great. So Casey, what would you do?
Well, I would stop the PPI, stop the checkpoint inhibitor, and I would start steroids. Sometimes, for the most part, I mean, that's the treatment, is stop the offending drug, put them on steroids, and the hope is complete remission. And, about half of them go into complete remission. The rest go into some kind of a partial remission, and a few progress. But, I've had some pushback from oncology. If they're really, hone in on treating the cancer and they want to continue, they put them on steroids and don't discontinue the drug. And I've had 1 or 2 cases that happened, and the creatinine sort of doesn't get better, but it doesn't get worse. So I don't, it kind of depends on the oncologist. But if this was in my hands, I would stop the CPI and put the patient on high dose, prednisone 60, and kind of follow the creatinine and see if it gets better.
I mean, in some respects, you're picking your poison in cancer or interstitial nephritis. And we know that these drugs in certain cancers and certain situations can be fairly miraculous. I don't want to use the cure word, but I mean, they're pretty amazing drugs. Mm-hmm. And you hate to just flippantly tell the oncologist to say, well, we've got to stop this, and I think it's real important, like you said, to work together and try to figure that out. Bill, you want to guide us through?
I think, Roger, so if I might quickly intersect here, I think one would also have to look at the level of chronicity, right? If you have a patient with very advanced IFTA and there's not much tissue to salvage, and there is a chance that the patient will likely benefit highly from the checkpoint inhibitor, you may want to treat through it rather than stopping it. I've been dealing with very similar situation with another patient of mine who has pretty advanced IFTA and has colorectal cancer. He's getting checkpoint inhibitor, and the dilemma is what to do. And they're referencing some response rates and full remission rates of 50, 60+% with checkpoint inhibitor, and the patient's biopsy shows 75% IFTA. I said treat through it. So he had AKI recently. We gave steroids, and then he continued with Keytruda. So I think you kind of have to look at how much chronicity is there or renal tissue to salvage when you make the decision.
Vesco, was that a transplant patient as well?
Transplant patient, yes.
And was the transplant working?
Yeah, I mean, creatinine of 3.5 with about 75% IFTA. So it's working. Patient is not on dialysis, and then had an AKI. Creatinine went from like 3 to 4.5. Got steroids, went somewhat down. And then the oncologist, told me that they would like to continue with Keytruda. I said, I think if we can salvage the patient, we should try to salvage the patient rather than this kidney the patient had for plus of 20 years. So I think I just made that, decision together with the patient that it will be better for him that he continues with the checkpoint inhibitor because he's likely to respond to this. rather than trying to salvage this already quite damaged kidney.
Yeah, but it does bring in a whole nother, element to treatment when you have, you're fighting a cancer, but you also don't want to automatically reject the kidney. And I'm sure,
Oh yeah.
you see no shortage of cancer in transplant patients.
No,
that are
I mean, this
prolonged.
scenario is very common.
This is going to
that
come
I'm-
up. Yeah, I'm sorry.
Yeah, this scenario is very common that I'm
Yeah.
referencing, kind of between losing the kidney, losing the allograft, and potentially salvaging the patient. And I think in that case, we try to see how much chronicity is pre-existent before patient has developed cancer, and fortunately, many of these patients we already have kidney biopsies performed, so we know not only what was their baseline creatinine, but how much IFTA there was going into this chemotherapy. So to some extent, it's easier to make some, I think, decisions regarding that. Would you try to salvage the graft, or would you try to rather salvage the patient?
Yeah.
So.
Thanks. That's useful input. Bill, you want to walk us through what you did?
Hey, Roger, just one more thing. But it's important to know about the re-challenge component, because when this patient gets the steroid treatment and then you actually want to go back and give the patient nivolumab, the re-challenge beta is now there, whatever, at least from 4 studies, is 25%. It's less, so yes, it's 25%, but the 75% chance that it's not going to happen again. So the AIN re-challenge data is 25%. No matter which drug you choose of the class. But again, that data comes from small number of patients, like 7 patients, 25 patients. And I know David Leaf is collecting a larger series right now. Hopefully we'll have some better information, but I would still re-challenge once the treatment is done with steroids, or concomitantly treat, like you said.
Yeah, that's I'd forgotten about that. That's a really remarkable finding that it's as low as it is when you think about it. But Bill, take it away.
Yeah, thanks, Roger. I was talking about checkpoint inhibitors on rounds with my team of residents and fellows, and one particular resident really was always short on words. She was very to the point, and I just said, "What's the effect of checkpoint inhibitors?" And she said, "Itis." She didn't even say. She just gave me a suffix. That's how, but that was the perfect suffix, because just like Kanar said, it's really inflammation everywhere, and this is kind of how it happens. I mean, normally we have T cells coming up to the tumor cell, and then the tumor cell itself is able to, through binding, is able to sort of deactivate or create energy or make the T cells kind of go away and die. And what oncology has done is found out that when you give the checkpoint inhibitors, you can block that inhibitory signal and allow the T cell to really proliferate, which is amazing, because then that T cell population can go and destroy the tumor. But it can also destroy host tissue. And so we do see quite a bit of itis, as my resident had said. And so you'd think it would really just be a T cell storm, but the inflammation is really all over the place. The T cells obviously can even bring in B cells, then you can get circulating antibodies, you can get immune complex mediated disease as well. And so it's not just really a T cell, posse immune type situation that we might see in the kidney. You can get, like you guys were saying, you could get a C3 GN, you can get immune complex GN, and then obviously the most common side effect is interstitial nephritis. And so it can be itis everywhere, though. And so just like Kanara was saying, if you have a person who has vitiligo, then the itis is somewhere else, and that's another sort of poor prognosis if they have multiple sites of itises all over the body. And I think about, obviously, in the kidney is the most common one that we would see, and it's interstitial nephritis. And just like you said, it's a lot more common when you have a concomitant PPI. It doesn't have to be eosinophilic. It often is eosinophilic. And the timing is very interesting. In this article by Gleiserman, they kind of went over that a little bit. And it doesn't, we're so used to seeing somebody getting a sulfa or getting a penicillin and then develop the AKI afterwards. But it's really not necessarily the drug effect itself that's causing the inflammation. It's really the drug that's causing T cells to proliferate, and then those T cells do it. So this is really an extended effect of T cell activation as opposed to a specific drug effect. And I think Gleiserman went over that point really well in this article. You'll see Kanar's name in a lot of different places over this little 5-minute spiel of mine, because he's written so much about this, and that's why we're really happy to have him on today. But the glomerular pathology is just like he was describing. The most common is actually post-immune GN. The nephrotic ones, we do think about, it's really just inflammation everywhere. So you think about your T-cell mediated podocytopathies is probably the most common. Kanar and I published some cases of secondary amyloid, again, from chronic inflammation, just like you would get in your, skin poppers, your inflammatory bowel disease. You can get a secondary amyloid, and here's some figures from our paper, or membranous. And so there's an inflammatory component on the nephrotics, and then there's an inflammatory component on the nephritics too, post-immune being the most common, but C3GN, interestingly, being up there too, and anti-GBM disease as well. I've never seen an anti-GBM pretty high on the list of any differential, really, especially one that's secondary, but there were some reported here. So that was interesting and news to me when I was reading this article. And so what do? That's the final real point. What should we do? Should we give steroids? Should we stop the drug? And luckily, Mayo Clinic's experience has kind of guided us, where they had 14 cases. So this is not based on a ton of data, but they had 14 cases where they held the drug, and just holding the drug alone did not help. But if they gave steroids, they actually got some complete response and some partial response. They did not give steroids, and there wasn't much of a response. And then the re-challenge data is just as Kanar said, we get about a 25% recurrence, 1 to 3 of after the drug has been reinstituted. And so knowing that some of the, just like Casey said in the beginning, some of the oncologists say, no, if we give steroids, it's really just going to hamper my cancer treatment, and we can't do anything because the cancer is so severe. And I have to say that this patient, his cancer, hold on there. This is his PET scan, and oops, Praveer, I don't know if we can go back to that. Did I go all the way back to the beginning? Oh, there we go. Thanks. This is very interesting. I know it's a little bit blurry, but this was from June to April, so it's 10 months apart. This is his PET scan showing the masses are everywhere. And this is a CT scan after he started on the checkpoint inhibitor. So this was also a patient who had been to 3 different cancer centers, gotten so much radiation and chemo over the years. He was actually told to, make his final, that was it, go to palliative, and there was nothing else that we could offer. And Rush, I think, was his 4th opinion. And the oncology team here tried to give him this checkpoint inhibitor. And for the first time, they were seeing shrinkage of his tumor. He had brain mets, bone mets, liver mets from this horrific sarcoma. So it really was amazing that he had this great response. So I was a little hesitant to give the steroids. I thought this is really a lot more important, but the oncologist actually said, no, it's okay. We can give it for a month, and let's try that. And so that's what we did. We gave 60 milligrams of prednisone. His creatinine actually came down to normal. We did the 60 for about 2 weeks, and then we started a taper. I think he was off total steroids by 6 weeks. And he's actually been re-challenged. I held on to this case for a while before presenting it because I wanted to see the re-challenge data as well. And he's been re-challenged with the drug, and he's not had a recurrence of his interstitial nephritis. We also were able to stop his proton pump inhibitor, and he had some significant dyspepsia. But when we investigated it, we actually found out that with an EGD, he had a fungal Candida esophagitis, and we could get really targeted therapy there, so we didn't need to do the anti-acid therapy. So it was really a big success case for him, and he's still able to get his checkpoint inhibitor, which has been the only thing that was going to really save his life.
That's great. Kanar, is there any data on how long you need to treat this, or just like you follow the creatinine and pretend like we know what we're doing?
So this is one of those cases I think we're learning as we're seeing these patients that we don't really need to treat AIN that long. I've treated as low as 1 month, like, mentioned, and as long as 3 months. And it's all variable based on the cancer response as well. So I'm thinking more and more in general AIN, do we really need that long of a therapy even? Now that we are learning more about this AIN from checkpoint inhibitors.
Do you have any explanation why re-challenging, is there any theory out there why re-challenging wouldn't rev it up again? Or does everybody stop the PPI, and that's why maybe the other aspect is not there?
Might be tolerance, like a transplant, maybe something.
Not transplant, I meant the
No, it might be still tolerance of the immune system of the drug. It's second time around, it's possible.
Yeah. It's great. Kanar, do you have any other points you want to make about this disease. And
No, I think you guys covered a lot. That's awesome. Thanks for having me.
Can I ask just one question?
Yeah.
And correct me if I'm wrong. I think the idea is such that if patients actually develop itis, that is a good sign that they're actually responding to the tumor. So, if they develop interstitial nephritis or one of the other, forms of inflammation, that's actually a prognostically good sign for them. So I think that's something for us that we should not necessarily back off and, not, just because they have developed interstitial nephritis, say, okay, we're going to be done with our checkpoint inhibitor, but, actually on a contrary, proceed, give more of it.
At least in the non-renal literature, there is definitely data that adverse immune events have better prognosis of cancer, but the recent Spanish data showed actually AIN had a higher incidence of mortality in the patient. So that's the first paper to show that. It was in, I think, NDT recently. So I don't know about AIN yet, because, when you start affecting organs like the kidney and heart, I don't know if that actually is a better prognosis for the patient. It might actually be harmful.
In terms of cancer diagnosis, at least, I mean.
Yes, it is. Yes, for cancer, yes, yeah.
that's a really good point, because I'd forgotten about that. And it reminds me of the hematologist sometimes saying that a little bit of graft versus host is a good thing to have for some of these hematologic diseases. But, you don't want so much your skin is in bad shape and you get renal lesions and everything else, but a little bit is probably good. And probably a little bit of itis is a good thing. You just don't want too much itis.
Yes.
So, well, great. Let's wrap this up. Kanar, thank you very much for joining us. It was a pleasure and a joy to have you, and we appreciate your expertise.
No, thank you. Happy Kidney Day.
Happy Kidney Day, everybody. The CME activity code, to remind everybody, is 481829. Everybody stay safe, and we'll see you all next week.